So much, Amy and Mahela and everybody who made this possible. And I wish we could all be there in person. But thanks to this technology that allows us to gather virtually. And I just want to say first, it's really extraordinary what you're doing to preserve this history, and it's important. And one of the things that I like to talk about is in reflecting upon our history, and particularly now as we're going through this pandemic, reflecting upon our history when it comes to healthcare and putting it in the context of everything that's going on in society is something that I think can be very helpful to us, which you're already doing. So I'm gonna, what I'm going to do is give you a brief overview of the field of narrative medicine, which I'm guessing probably is not exactly what you might think it is, because the name is kind of ambiguous, I think in a productive way. But I'll just tell you a little bit about the history and scope of the field as it stands now, some of the key points, a little bit about my own work within the field, and then we can open it up for discussion and questions. I think there are a lot of really fruitful connections. The narrative medicine sounds like stories about medicine, and that is part of the field. And it makes sense that that would be what people think that it is, because that would be a good description for that. And as I say, it absolutely is part of the field. But in the history of the field, which is not that old, it's quite young. In the history of the field, the original meaning of narrative medicine is as a way of practicing medicine. Narrative medicine would be medicine practiced with an attentiveness to narrative. So originally it was quite clinician focused, and it still has that as part of it. But the idea there is that the clinician, mostly physicians originally, but now more inclusive, in attending to the story of a person who's in the role of patient, must be attentive not just to the data that they're gleaning from what that person is saying and how they can take that data, put it into their differential diagnosis, put it into electronic medical record, but also to be attentive to the way that that person is telling their story. And that's a narrative attentiveness. And the parallel here is between listening and reading. And so in this model of practice, the clinician, in addition to attending to the data, which of course they need, would also be attentive and attentive towards and respectful of the way that the person chooses to tell the story. So where do they begin? What kind of voice are they employing? What do they leave out? All the kind of questions that you would ask in a literature class in trying to unpack what's going on in a poem or a novel or a movie or spoken word, or we say literature, but it's really a very inclusive understanding of what narrative is and all the different forms that it can take. And one of the misconceptions, if you hear this description, is then that this means that the clinician has to sit there for 3 hours, and then clinicians in the audience inevitably say, "That's nice, I wish I could do that." That is not the reality of clinical practice. I don't have time for that. But that's actually not really the idea. The idea is that in whatever amount of time that you have, so each of you, I just see these little black boxes, but I know there's people out there. Each of you knows if you're giving an account of yourself to somebody else, particularly I would think if it's an account of suffering, as one often has to do in consulting with a healthcare professional, kind of intrinsic to the situation, but maybe in any context, that immediately whether that person is actually attending to you, or whether they're just waiting for you to finish talking before they respond or do something else. And so that kind of attention to what you're saying and the way that you're saying it and your lived experience outside of the strictly biomedical scope of your medical situation, all of those elements go into, first of all, giving the clinician a better sense of what's going on with you if you're in the patient role, and also making you feel heard, which is going to strengthen the affiliation between clinician and patient, which is going to result in better care. And this does connect to, Amy, what you were talking about a bit in terms of the context of the sanatorium and the attention to the whole person. I thought it was interesting the way that you put that in context to the fact that there really wasn't much that could be done, unfortunately, for people at that time medically, strictly speaking medically. So then the attention goes to the other elements of people's lives and the whole person. And this, I think, is something for us to reflect upon, because I'm sure you all have your own views on this, but is it the case that in the time since then, so you look at the 20th century, now we're in the 21st, but the incredible changes in the degree of the technological, the role of technology in medicine, the role of pharmacology in medicine, the change in institutions in medicine, and narrative medicine arises as one of a range of critiques of the situation, not to say that it's not opposed to the medicine itself. I mean, that's not my stance at all. I'm not an anti-allopathic person, but I don't speak for everybody in my field. But it arises in response to how an exclusive emphasis on the disease process, sorry, my hair is falling out of my earphones in a funny way, how an exclusive emphasis can be reductive, often is reductive, and leaves out the lived experience of the person, of the individual who's in the role of the patient. There's a nice formulation or a nice set of terms that makes this distinction that I find helpful. It originally came from a fellow named Andrew Twaddle, and then it was popularized or discussed further by a prominent scholar in the health humanities named Arthur Kleinman. And Twaddle originally made this distinction between disease, illness, and sickness, which we often use these terms interchangeably. So this isn't to say that this is the right way to use these terms. It's just a way of making distinctions that we don't often make. So in this way of defining these terms, then disease would refer to the biological process. So it would be what's going on in the strictly medical sense for somebody who has TB, say, right? And then illness would be the lived experience of that disease. How does a person feel? How is it affecting what they can do and what they can't do and where they live, right? Do they have to go and live somewhere else and sit out on a porch? How the disease can have a profound impact on their lived experience. And then sickness is the social recognition or lack of recognition of the disease. And so one way of, I think, narrative medicine and a lot of allied fields are really trying to emphasize the illness and sickness aspects. We'll leave sickness out of it. It's just like disease and illness are the helpful ones. Emphasize the illness part of the equation. And not to say that the disease part doesn't exist by any means, but just that attention to that lived experience of the individual is something that, in the view of many people, myself included, does not get enough attention in contemporary healthcare. And again, I'll keep emphasizing this. I don't see this as being at all opposed to biomedical advances, but I think most of us who have experience of contemporary healthcare are aware of the ways in which one's personhood and one's individuality and one's social circumstances can seem not to have a place. So that brings us to the development of narrative medicine as a field. I said it started off as a way of practicing medicine, but it's a really interesting field because it's that and a lot of other things. And this brings us a little bit closer to the kind of work that you're doing in attending to the accounts of people who are in the role of patient in the sanatorium, and all the other people who were involved in that social community, right? And that is the part of the field that is interested in those narratives and in elevating the voices of people who are in the role of patient and caregiver. Caregivers who aren't physicians are historically not, they do not get as much attention as they might or as they should. And then also asking questions about, I mean, the through line is narrative. So narrative is at the heart of the field. So, but once you're privileging narrative, then that brings in a lot of different questions. So you can say, well, how is the narrative of this institution or of this disease historically constructed, right? What is it? So this goes back to, you know, the clinician attending to the narrative of the patient, and not just in terms of the data, but also in how it's structured and what does it leave out? Remember all those questions? You can ask those same questions, and we should be asking those same questions at the level of social institutions and of history. So another thing, Amy, that you were mentioning was this question of how when we're looking at something that happened historically, and there were certain societal standards and ethical standards at that time, say, that were dominant, not to say that everybody agreed with them, but now time has passed and perhaps, hopefully, we have different set of standards. Certainly, I would hope when it comes to race, although it's a work in progress, then there's a very open and interesting question of trying to be attentive and critically attuned in how that historical narrative is constructed and reconstructed over time, right? And how is the way that we're telling that story now functioning? How is it serving to perhaps support a certain narrative of what we're doing now as a society and within healthcare? How might a contemporary narrative of something that happened in the past try to be reparative? So try to elevate the voices of individuals whose voices were not heard at that time. And that seems like one of the things that you're doing, and it's an active process. And that does have a lot of crossover with the field of narrative medicine, because as I said, it starts off in the clinical context, but then more broadly, it's asking questions about equity and social justice, and with narrative as the through line. So again, once you're understanding basically everything that we can talk about to be in the form of a narrative, because you know, how else can we discuss things, you know, even if it's not in a standard form, then that immediately opens to a wide set of questions. A lot of them are ethical questions. So who gets to tell the story, right? Who doesn't? Whose voice is not heard? When does it begin? What does it end? What does it emphasize? What does it leave out? And I think of it, actually, it was a colleague of mine who came up with this analogy, but I like it very much, which is that narrative is like the idea, you know, focusing on narrative is more like the engine of the train. And it's very useful. And once we start asking these narrative questions, though, it carries behind it everything else. Because once you start looking at something as a narrative, then you start asking, well, how is it constructed and why? Whose interest is it serving? Whose interest is it not serving, and so forth. And the thing about contemporary healthcare, so I teach, I'm the director of the master's program in narrative medicine at Columbia University. And that's a mixed, I can talk a bit later about some of these logistics if anybody's interested, but that's a program which is mixed. We have clinicians and non-clinicians, and we have a lot of young people who are heading off to healthcare profession school. But the field is intrinsically interdisciplinary. If it's skewed too far in one direction, we would admit more people who have different kinds of backgrounds. It's really important to the field that that's the case. And another field in which that's the case, or it should be, and one that we're really allied with, is bioethics, of course. You're all familiar with the field. It's been around for longer. And But there's also within bioethics, there's a branch called narrative ethics, which is very similar to narrative medicine. They just have different names because they kind of came from different sources. And so I also teach bioethics, and in that context, often there are a lot of clinicians who are learning about bioethics for their work. And this bringing in the train of talking about narrative and then seeing virtually everything as a form of narrative is, in that context, actually kind of subversive, because it threatens the authority, the authority of medicine by saying, well, this case report format that medical students are taught and that everybody uses, and it becomes second nature and so forth, that, not saying good or bad, but that also is a form of a story. That's a narrative, right? So, well, what's so dangerous about, like, what's so subversive about, what's dangerous about that? What kind of stakes are there? Again, once you do that work and you understand it as such and saying, well, it does structure the story in a very specific way, and that has effects, so it puts the subjective experience of the patient in opposition to or in a different category from the objective findings of the clinician, of lab reports and so forth. That has an effect. The effect is different than it would be if you had a different form of the narrative, right? So once you start asking those questions, though, then the question of ethical responsibility comes into play, because it's not neutral. And within healthcare, the idea that it's neutral, that it's objective, is still the way a lot of people think. And it's easy in talking about these things to fall into a good-bad polarity, and that's not, in my view, that's not at all what my interest is. It's more, how can we bring in tools to have a productive conversation about these things, right? So it's not about who has the right story or who has the wrong story. I mean, maybe in some cases there are right stories and wrong stories, but most cases it's a lot trickier than that, right? And then asking questions like, well, who has the right to tell a given story? Is that even the right way to frame it? Is it about rights? A lot of people, including some of my colleagues, use the phrase "who owns the story." I think can be helpful when you're talking about issues of appropriation and trying to reclaim the authority to tell one's story, especially if that's something that has been expropriated. On the other hand, is a story something that one person or one group truly owns, or can we have an understanding of story as something that's quite complex and dynamic? So with this institution, the story of the institution lives on. I mean, it lives on today. We're talking about it right now. How we talk about it, about the sanatorium and its role in that particular place and time, and what it means to us now, is something that we are recreating, right? And so we're, in a sense, part of that story. So what's our responsibility? What are the effects of the way that we're talking about it? So those are some of the key points of the field. It's pretty expansive, though, so it's hard to give it in a nutshell. But if you're interested in learning more about it, I can put in the chat a link to a short article that I wrote, sort of summing up the field precisely for this reason, so to give people a sense of some of the key precepts. And I can also direct you to a book that my colleagues and I published a few years ago called The Principles and Practice of Narrative Medicine. And I have this blur filter on, so it's hard to see the whole thing. I'm one of the co-authors, and also Rita Sharon, who's really key original figure of the field, but she developed the field in collaboration with a number of colleagues who are coming from different disciplines: philosophy, English, public health, medicine, and that is really important to the field, that is the case and that remains the case. And that's similar to bioethics is interdisciplinary as well. And the idea there is we can't have a conversation about what we should do as a society when it comes to research ethics or any number of things within bioethics if it's just the researchers or just the clinicians. And so that was a field that very intentionally tried to create a big tent saying, let's bring in the philosophers and the lawyers. I know that doesn't sound like a very big tent, but and also anybody who has a body and has a stake in ethics, which is hopefully all of us, to be part of the conversation. And that's also part of narrative medicine as well. And then one other reference, which is, this is my book that came out earlier this year. That's the Blade Runner unicorn on the front. It's called Metanosis, Revelatory Narratives of Health and Identity. And if you've never heard of this word metanosis before, that's because I made it up. I made it up because there was no other word that I was aware of that described what I was writing about, which was the experience of learning that you have a condition, a longstanding condition, experience of learning about it as an adult, and not having been aware of it before. So it's not when you know you have a medical problem, but you can't get a diagnosis or satisfactory treatment. I mean, this is when, so this happened to me, that I learned in adulthood that I have a big visual field defect that I had all along, but it was never diagnosed before and I wasn't aware of it. Once it was pointed out, it was glaringly obvious to me, but it was very unsettling because from one moment to the next, I suddenly had this knowledge. And then I started to think about people who have this experience with conditions like ADHD or mild autism spectrum disorders. These are conditions that have had so much diagnostic expansion in the last generation or so that there are a lot of adults now who are learning that they fit the diagnostic criteria. And so they have to reconcile this with their sense of identity, their sense of self. And the effects can be really mixed. In a lot of cases, people are really relieved because they've been carrying so much shame and feeling a responsibility for a condition like ADHD. Like, why can't I concentrate in school? What's wrong with me? I'm just lazy and bad, right? So they're really relieved to know that there's a explanation for it in many cases. And also it gets more complicated because you're also then being told that who you are, or a central part of who you are, is pathological, that you have this disease designation, to go back to that distinction. And just very briefly, I think one aspect of this topic, and it's one that I touch upon in the book as well, that also intersects with this question of history and looking at history from the present, is that when that happens, and let's say you get a diagnosis of, you're middle-aged and you get a diagnosis of ADHD, and it changes how you understand your own childhood. Let's say you suffered from not succeeding in school because you just weren't adapted to it, but nobody at the time knew that you had this disease, or it wasn't even being diagnosed. So what do you do with that? I mean, do you judge your parents and teachers from 40 years ago because of something that wasn't even in the DSM yet? It's the psychiatric diagnostic manual. Or do you have a different way of understanding it? And the same issue comes up with ethics, right? Judging the past by the standards of the present, which is often called presentism. And so a lot of these are issues that we're grappling with. And so that's what the book is about. It's more philosophical and narratological. And then I also interviewed a bunch of people and told their stories. And that also, I think, connects back to this question about how do we tell stories. And I used oral history because I didn't want to just tell stories of people who were in clinical case reports or who had made it into the medical journals. And it's a democratizing impulse. It's trying to make people's lived experience, again, that the illness experience or just their lived experience, trying to accord it respect and to honor it and give it importance and put that into conversation with other perspectives on that issue. So I think I'm going to stop talking so much right now, and we can open it up for discussion and questions. And about any aspect of this.
So folks, feel free to, if you have a point you want to raise or a question, to unmute yourself and ask it on your own. But if you'd rather put that in the chat, I'm also happy to read it for you.
You know, while people are thinking of a question or a comment, my brain is absolutely full of, of them, as I'm sure some of the folks that I see on this Zoom who think a lot about our local history. There's so many connections, but I guess one thing that I would just throw out there that I think is really interesting, it's something I think about often with our local history is, you know, in Mahela's introduction, she was talking about how we understand our history by these recorded stories that have come down to us. But something I think about often is that who, you know, not everybody had a chance to record their stories, and I suspect that they sort of skew positive, because you had to have a certain degree of wellness to be able to share your story, a certain amount of wealth and you know, the means and psychological means, whatever. There were many different things that you need in terms of the support to be able to share your story, either written or you know, in a letter or in a diary or a memoir. And so that's just, I think, something I often think about, and I wonder, I see some historians on this call, and I wonder if you guys have any thoughts about that or something else as this relates to some of the things Danielle talked about.
Well, I have a sort of comment slash question that sort of can lead off of that, Amy. And you know, you mentioned doing oral histories and the idea of, you know, the subjective sort of story that the patient can give, but then, you know, the idea that medicine often is trying to be objective. And, you know, we often use oral histories to collect the stories that we tell at the museum. And the sort of whole point of oral history is that it is objective and you're getting a person's experience and it's more candid. And one of the things that the oral history field warns against is not to sort of disregard what someone tells you just because they might get something factually incorrect. So if they, you know, maybe say that something happened on a certain date, but that is factually incorrect, that doesn't mean that what they're telling you in the story is wrong, just because they got the fact wrong. The fact that they're remembering that a certain way or remembering that happening on a different day can be telling and can be an important aspect of their story. It can give you, you know, that inaccuracy can give you more information. So how is that reconciled in a field like medicine that, you know, facts and data, you know, can make such a big impact on the outcome of someone's wellness, you know, getting the information correct and things like that?
Yeah, I mean, you go right to one of the central tensions within our field and within medicine. I think that there are different forms of accuracy. If there's only one kind of truth claim that's being valued in a given scenario, which is, say, what factually happened with this person's body, right? Then other forms of truth claims aren't going to make it into the narrative. They're going to be discounted. And this is where things get a little thorny, because if you say, like what you just said, which is to say, like, well, respecting somebody's account, even when there are factual inaccuracies, there are other kinds of accuracies, like the fact that in most cases, there's nobody better equipped to tell the story of their own somatic experience, say their lived experience of illness or pain, right, than that person. Then one can accord more epistemic, which is about knowledge and knowledge claim, more epistemic authority to what that person is saying when it comes to that illness experience. And in my view, that can coexist alongside, say, there being another better authority that can speak to the factual record, if that's what's happening, or that the MRI reveals, as the words go, reveals things that are not evident to the person whose body it is, right? And that's a different kind of authority. The oral history, the field of oral history is, and so as you were saying, is grappling with these questions in a really interesting way. I think Dory Laub writes about this in the context of Holocaust testimonials, and there's a story of a survivor of the camps who remembered, and I don't want to get this wrong, so I won't give the details, but remembered there being a kind of uprising and an explosion of the crematoria, and said that three of the crematoria chimneys had been toppled. And then that person's account was called into question, because then the historical record showed that yes, it had happened, but it was only one chimney. But Laub's point, if I'm getting the reference correct, Laub's point is that he's not denying that the historical factual record, but saying that it was so inconceivable to the people in the camps, in the detainees, that there would be any kind of action taken, that there was a kind of reality being conveyed with the inaccuracy. You see what I mean? So like, can we hold those two things in tension without immediately saying, oh my God, if you're going to talk about the importance of story, then you don't care about biomedicine or realism, and you're just a nihilist and a relativist and a skeptic. You know what I mean? Like, then we just very quickly wind up in a place where there's no possibility of dialogue, as opposed to being able to say, well, actually, we want to elevate the possibility to hear these forms of truth at the same time as understanding that there are different kinds of truths that are different kinds of claims that people can make. And I also, the terms subjective and objective are really interesting and tricky. And there's a scholar, William Donnelly, who made the point that subjective, when it was introduced into a clinic note, so in medicine, these terms are used all the time. Medical students are taught to do a SOAP note, which is subjective, objective, assessment, and plan. And so subjective is, if I say I hurt my shoulder and my shoulder hurts, that would fall under subjective. But originally, subjective just means, it's just a ontological designation, which has to do with being, which is saying it. I'm just saying that my shoulder hurts because I'm the one who knows if my shoulder hurts or not. That's why it's subjective. It's coming from me, the subject, right? Mm-hmm. But when we say, oh, that's so subjective, it has a different meaning, which is more of an epistemic devaluation, saying that it's not as reliable because it is subjective, right? So could we recuperate subjective, saying that it has a different kind of authority, it's not intrinsically unreliable? So whenever people use these terms, your ears should perk up and be thinking about what underlies that distinction. I think it's really productive to ask that question. And you don't have to use terms like ontological and epistemological to do that, but it's part of my professional malaise. So,
thank you. Go ahead, Suzanne.
It's such a thought-provoking discussion, and I really thank you for this, Danielle. I recently, just a couple of days ago, I attended a Zoom memoir writing workshop, and just listening to this discussion, I also have a brother who for many, many years has suffered from chronic fatigue syndrome, where so many doctors told him it was in his head, until he did a lot of research and kind of found his own semi-cure. And now with the COVID long haulers, there are very similar kinds of experiences, apparently. And I think back to, we've kind of evolved, I guess, over the decades and centuries from things that people used to be really ashamed about, that now the evidence is that, well, yeah, this is this is biological or biochemical. You know, it's not something that somebody can help, and I think that's probably going to continue. But it really, I mean, it's really a sort of fascinating thing to think about, how many people have really been harmed or hurt by this sort of judgmental attitude that so many of us have. You know, whether it's about someone who smokes or someone, you know, who's overweight, or, you know, we sort of pass these judgments, right, in the way that probably has always happened with mental illness or you name it. And you know, it's not really a question. It's just I appreciate the thoughts that have come to mind as a result of this discussion. So thank you.
Well, thank you. That's my fondest wish, is that it prompts questions and interesting conversations. So I really appreciate that. And also, thank you for sharing the story about your brother. And that too, I think I'm just gonna, you know, I was speaking about the disease, illness, sickness rubric, and in my book, my father is a mathematician, so I couldn't help myself. I made a little Venn diagram. Oh, it's gonna blur it out, but it's just a Venn diagram in which there are the three circles: disease, illness, sickness. And the reason why I bring it up is because chronic fatigue syndrome is a really challenging but good contemporary example of a condition where people were experiencing illness. I mean, if you believe them, which I do, but the reason why I say that is because they encountered a lot of skepticism, and they still do when they try to get help from the medical establishment. So they're experiencing the illness, which is the lived experience, saying, I have chronic fatigue like this, or these are my symptoms. And then they go to the medical system to get a designation of disease, which would be a valid diagnosis, and so often are refused. And then the sickness would be the social validation that you have a real condition, and that you can get things like be excused from work if you're sick, right? But again, going back to the other term that is always useful to sort of perk up your ears when you hear it in this domain, I think, is the real, because you also mentioned that, you know, getting a real, you know, finding a biological basis for something gives it credibility because it's real. And again, I'm not a anti-allopathic. I'm actually pretty aligned with contemporary Western medicine in a lot of ways. But the idea that it has an exclusive claim upon what's real, to me, just seems patently absurd. I mean, many of you have know people, or in your own families have familial relations that aren't biological, right? And often when situations like that come up and you say, oh, he found out that, you know, he did ancestry DNA and found out that his father is not his real father, right? That's the way we often use these terms. But the premise of that is that the only way that relationship is real, you can be a real father, is to share, genetic paternity. And that's just not the case. It's not to say that there isn't a difference, or that there isn't such a thing as biological paternity. But to say that that's real and that all else is unreal is to devalue so many forms of our lived experience. Do you know what I mean? So social bonds are real. You know, somebody said to me once, well, you know, money's not real, it's just a construct. And I said, well, that's nice. Can I have your bank account then? Because of course, you know, constructs are real too. They have a profound impact on how we live our lives. Diagnoses are constructs, but they're very real. Again, it's not to say that there's not a distinction, but I think that can help us, unlock ourselves from some of the kind of battles that we find ourselves in.
We have a question in the chat from Susan Williford. What do you think the impact will be with the COVID narrative, especially since it is reported that people are asking that COVID be removed from death certificates?
That's a great question, but I want to know what you all think. I mean, the COVID narrative, what is the COVID narrative? We're in the middle of it. It's a chaos narrative. I have no idea what the COVID narrative is going to be. maybe that sort of speaks to your question, because we just don't know. And even right now, if we're to try to describe what we're experiencing right now, there would be so many narratives, right? I don't know. I mean, I think it's helpful. Well, this does relate to this question of this institution and the fact that your organization exists and that we're having this conversation, because we have to ask your question, and then we have to keep asking it over time. And it can be very helpful to compare our current predicament with narratives from the past. So good thing that you all are keeping that narrative alive. So one thing I do think about in regard to what we're all experiencing right now with the COVID pandemic is that there is history that most of us aren't aware of. I mean, we tend to think that what we're going through right now is unique, right? But I mean, vaccine hesitancy or refusal, both of those are kind of loaded words, but in the 19th century, the smallpox epidemic, there was a vaccine that was developed that was really miraculous, saved so many lives, and there was a tremendous amount of resistance to it. Some of it was very well founded. I'm making a value judgment there, right? Because I'm saying that it had to have a certain basis for it, but there was also a lot of social inequity that got played out with how the vaccine was administered, which I don't have time to go into now. So asking that question and comparing it with narratives from the past can be really helpful. But yeah, if anybody has an answer to that question, I'd be really curious to hear it. It's good to be asking it though. Susan, are you here? Yeah, go ahead, Amy.
That just inspires me to give a little plug for our current exhibit that we all worked to get up and installed recently, Pandemic Perspectives, and it's pulling out different sort of reactions to the current pandemic and tying them to our local history. And we had fun working with your colleague at Columbia, Arden, I don't know how to pronounce her last name. Hegel.
Yeah.
So she shared with us her syllabus for her course on literature, pandemic literature, pandemics in literature, and we were able to use some quotes from the things that she worked with. So yeah, I mean, I think it's been fascinating to have conversations with people at the museum about their reaction today, linking it to the past, and I think we find ourselves understanding the current pandemic a little bit better comparing it to the past. But I think I also find myself understanding our history a little better by what we're living through. We can tend to look back on the past and we just see it as one thing. Oh, right. TB patients came to Saranac Lake and they had this glorious experience and many of them got better. Right now, we don't simplify it that much, but it's easy to kind of just tell one story. And when we're living it today, we realize how messy it is. And history is messier than we think.
Yeah, I mean, exactly. Like that's a historical conundrum, because if it's so confusing today, and if I can't answer that question remotely, and even if I could, it would only be valid for me, and we can't really make sense of it in a cohesive narrative fashion, then why should it get easier over time? Like it doesn't. The fact is that we come up with a historical narrative, and I think that problematizing that and asking questions about it is the ethical thing to do. So it's good that you're doing it.
I think what I was trying to get at also was back when you were talking about the patient's truth versus the record. That's when I came up with the question. And so my question, I guess, is sort of how do you decide as a historian what's true when you've got people changing the record?
I don't think you can. I think you just have to work with what you've got. Sorry to jump in, but Amy brought up the point that many of the records we have from patients that are written records talk about it being an overall positive experience when they came to Saranac Lake to cure from TB. And something I've noticed in the response cards that people can fill out for our Pandemic Perspectives exhibit is that when people have the time to sit down and sort of craft the narrative that they want to share, they're writing it down. So they're thinking, they're erasing and replacing words, they're taking the time to craft it. They choose to tell a more positive story. We have people latching on to words like gratitude and creativity but then when they come up into our sort of visitor spot and talk to me in person more candidly and more sort of off the cuff about their experience, it's a little more diverse in what they choose to tell. There's both positive and negative shared when people are just sort of going for it, so to speak. So I think that's something that we just have to be aware of as we see those narrative outcomes. Maybe Danielle, you have something to add to that as well.
Yeah, no, I think that's really helpful. There's another set of terms that I think is useful here from the sociologist Arthur Frank, who wrote a book about, he's a scholar of illness narratives, and he defined 3 different types of typologies in illness narratives. And the really dominant one is the restitution narrative, which is the one that says, okay, I got sick, but I'm going to get better and I'm going to be as good as new again. And the other 2 are, one is the quest narrative, which is what it sounds like. It's illness understood as a journey, which you often hear with when somebody gets a cancer diagnosis, for example, and then, well, you're going to go on a journey and of self-discovery, and it's often what people think or they're told. And then the chaos narrative, which is what it sounds like. It's the untellable story. But the restitution narrative is really predominant. And if you start doing an analysis of the ways that these experiences are presented to us in even pharma ads, or just the way people understand their experiences because they've absorbed this narrative, it's really dominant, and it can be prescriptive. So what you're describing, Mahela, is that somebody goes in, they're absorbing all this history, and they're crafting a personal narrative, and there's this bias for wanting it to be a redemptive narrative. But it's also because those are all the stories that we've absorbed, right? And so that's the script. But Arthur Frank, when he talks about these narratives, well, first of all, it's not as simple as that. He says that the illness narrative always contain elements of all 3. But the other thing is that he's not saying that there's any one of these is like bad per se, and I don't think they are either. It really depends on what that person needs, right? But what can be harmful is when one of those, like the restitution narrative, is so dominant that it doesn't leave space for people to have different kinds of narratives and to even experience suffering, because everything is supposed to be as good as new. Well, you know what? Sometimes it's not. Ultimately, it's not ever, because we're all getting older every day and we're mortal. And sometimes they're just stories and experiences that we absorb that are just really painful. And do we have narratives, narrative forms that we're allowed to use that make space for that? And that, I think, it can be really helpful to people, because, and that's one of the things that brought me into this field. There were a variety of different things, but I had a friend who did have a cancer diagnosis, and a group of friends and I were helping her at that time. And I remember very distinctly at the time, she said, well, I had this diagnosis and I'm going to have this surgery and chemo and treatment, but then I should be as good as new. And she survived, and she's doing great many years later, thankfully. But when she was really suffering from the treatment, basically, but she did suffer. And at the time, it struck me that she seemed like it was worse because she didn't have space for it. She didn't have a narrative structure that made space for that suffering. She was supposed to be as good as new. And she was, of course, she was profoundly affected by it, and she did suffer. And so how do we make space for suffering in a way, suffering and complexity in a way that honors people's experiences? Just a trivial question like that. I think there's a question here, but that would be more for Amy or Mahela, I think.
Yes, do we have any narratives captured from the 1918 flu pandemic?
You know, the current pandemic has inspired more interest, which is wonderful in our historic pandemics, and we've gotten questions about that. We have snippets of recorded information from newspapers and mentionings of things, and we sort of have compiled them on our wiki site. Some mentions and letters, and if Chessie, our archivist, is here with us, she could chime in here. But it's interesting that I think, at least in Saranac Lake, TB kind of overshadowed the flu, even, you know, when it was happening. And there was such this ethic of, you know, hygiene and kind of controlling disease in Saranac Lake was such a sort of group effort that I think that helped control the flu in Saranac Lake, or this kind of conversations makes you question absolutely everything. I'm like, did it really get controlled, or maybe it got swept under the rug? Hard to know, but we don't have a lot of stories of the flu in Saranac Lake.
But you know, I mean, in general, that pandemic is something that scholars in my field have noted is so there's so little in the historical record and in literature too.
Mm-hmm.
And there's a wonderful book by Andrew Ressick called Illnesses Narrative that starts off by, you know, talking about the 1918 flu, just how, you know, what percentage of the world's population died and why. Okay, it's not completely invisible, but why it really historically, you know, has just there's just not many novels written about it, or we just don't hear about it.
Mm-hmm.
And so I don't think it's just there that's the case, but quite widespread. And so then that would prompt us to ask us why that is. You know, relatedly, there's this beautiful essay by Virginia Woolf called On Being Ill, and she asked the same question. She said, why is there so little, it's not nothing, but why is there so little treatment of illness in literature? You know, we talk about love, we talk about mortality, you know, death, we talk about lots of things. We don't really talk about the illness experience, even though it is unfortunately basically intrinsic to the human condition.
Mm-hmm.
Well, on that note, it is 7:08. So I think we should wrap things up. Let everyone go get dinner if they haven't already. But thank you so much, Dr. Spencer, for taking the time to share all of your knowledge and research with us. This is really interesting. I can see Amy's wheels turning as mine are. And I've written down some new terms and things like that I think will be very useful and helpful to us in continuing to break down these stories. So thank you so much for your time and your knowledge. And real quick to our audience, we have one more speaker in this Humanities speaker series, and that is Beth Randall talking about occupational therapy. So be sure to go to the events page on our website to get more details on that coming up. And thank you, everyone, and have a great night.
Thanks, Mahela. Thank you.
Thank you.
Thanks, Dr. Spencer.
Thanks, everyone.